Today I will review the technique I use to harvest anterior iliac crest bone graft in pediatric patients. In particular, this bone graft will be used to reconstruct the maxillary alveolar cleft defect. Here you can see the instruments. We'll start with marking. The anterior iliac spine is palpated and marked along with the anterior iliac crest. Next, measurements are made 2.5 centimeters posterior to the anterior iliac spine, 2 centimeters lateral, and marking out a 2 centimeter incision. You can see that with medial pull, that incision lies over the crest, otherwise sits laterally. After prepping and draping, we're going to give local anesthesia to assist with hemostasis. The incision site is held over the anterior iliac crest. A 15 blade is used to make an incision through skin and subcutaneous tissue. Electrocautery is used to assist with hemostasis. I typically use very low Bovie settings, cut of 8 and coagulation of 10. Next, we'll introduce some skin retractors to assist with visualization. And then using pickups and tenotomy scissors, a combination of sharp and blunt dissection is continued down through the fascia. Next, electrocautery is used to make an incision along the crest through the cartilaginous cap, which you can see here. A small incision is needed, and you can move the retractors either direction to increase visualization if needed. After the initial incision is made with electrocautery, a new 15 blade is used to continue that incision down to bone. So the cartilaginous cap has been completely incised here. Next, 2 periosteals are used to elevate the cartilaginous cap medially with careful attention paid to stain in the subperiosteal, subperichondrial plane. A larger retractor is then placed to assist with visualization. This is a Cobra retractor from the orthopedic set. And now you can see the medial cortex of the anterior iliac crest. Bone curettes are used to harvest cancellous bone. The medial cortical plate is left intact during this portion of the procedure. Again, bone curettes are being used here to harvest bone. It's being placed in a cup with some saline and then transferred to a 5 cc syringe where the bone will be compressed. Additional bone is collected. After enough cancellous bone has been removed, osteotomes, a combination of straight and curved, are used to remove that medial cortical fragment of bone. In this case, there were 2 fragments harvested. You can see here's additional cancellous bone being packed into the syringe, and the saline's being sucked out, so you can see the 2 pieces of cortical bone here. These can always be morcellated if you don't end up harvesting enough cancellous bone. Irrigation prior to closure. I opt to use a hemostatic agent, which you can see being introduced here with a periosteal. And now the larger retractor is going to be removed. It's critical when closing this incision that the cartilaginous cap be rotated laterally. It tends to roll over medially, and it's really important that that cartilage cap is reconstructed appropriately, as this will allow regeneration of the underlying bone. This is especially important in cleft patients or patients that may require additional reconstruction down the road, since doing so will allow you to reharvest bone from the same site in the future. Failure to do so will result in a palpable defect along the anterior iliac crest. This is completed with 3 ovicral sutures. Scarpus fascia is closed with 3 ochromic gut suture, followed by dermis closure with 4 ochromic gut suture, and the skin is then closed with a running subcuticular 5-0 monocryl suture. The recipient site is prepared. The labial oral nasal fistula as well as the palatal oral nasal fistula are closed in a watertight fashion. The bone graft material is then introduced into the recipient site. Here you can see the cancellous bone being packed into the right maxillary alveolar cleft defect. After the bone graft material is placed, it is confirmed that the soft tissue will indeed lie in a passive fashion over the graft. Closure is completed using 4 ovicral suture intraorally. Tension-free, watertight closure here is paramount for the graft success. At the conclusion of the case, marking is given into the hip to assist with postoperative pain control. Steri strips and a Telfa dressing are applied.